Okay.
So a 56-year-old female who is a known case of extrahepatic portal vein obstruction presented with doubtful history of 2 episodes of melanina 10 days ago. On an endoscopy, you found large gastric varices. So our plan is to do US guided coil and glue.
Okay.
So over to Professor Kenneth Binmoeller. We shift to Professor Kenneth Binmoeller. You are online.
Okay. Good. So I literally just got myself. There's a little bit of an echo, so please forgive me if there's a little delay. So we have our therapeutic curved limb array endoscope that we're going to use. You do not have to use a therapeutic channel. You can use a diagnostic. In fact, I prefer the diagnostic. So we'll go in and start inserting. It's called endosonography because we have both endoscopic as well as US imaging. I'm going to very gently advance into the esophagus. And here now, is the gas on? Are we using CO2, by the way? Okay, that's great. And I'm trying to give a little bit of gas here to see. So as we go down, actually I got in pretty fast. You see the esophagus very nicely. And I think actually the oblique viewing optics of the CLA are very nice. We're looking at the cardia, looking for junctional varices. It's important to distinguish junctional from non-junctional varices because they're very different in terms of their management. So here at the cardia, I don't see any varices at all. And I can go clear into the stomach. We're not going to spend a lot of time cleaning this off. I'm just going to distend with gas. You can see there's very little pleural hypertensive gastropathy here. You can see the rule folds. Of course, there's always the possibility that some of these could be varices. We'll be able to distinguish that better with ETOH in a moment. This is just to show you that you can go in retroflexion easily with the CLA. You can see I'm giving gas, and you can look back on yourself. We should be able to see the fundal varices. I saw pictures and it was very impressive. It's just that it's a little bit dark here, but here you can see in the fundus area. Just wait till things. There are the varices down below. I think you can appreciate them down at the lower part of the image. Obviously, we're not going to treat these in retroflexion. The beauty of using ETOH is that it doesn't matter whether your stomach is filled with blood or food, you can still do the treatment. So now the first thing to do is to aspirate all of the gas out. I usually have the water pump attached to the working channel because you need to fill the fundus up with aerated water. You need to distinguish exactly where these fundal varices are. So the best acoustic coupling can be achieved, and the demarcation of the fundus, if you fill the fundus with water. This is one reason why I do prefer to have the patient intubated. This patient is not intubated, but the patient is in the left lateral position, and our assistant here is aware that we need to be prepared with suction to suction out anything that comes up, because we want to avoid aspiration. Primum non nocere. All right, so now I'm going to switch now to the ETOH. You can see the ETOH are just swapped. So the ETOH is large and the endoscopic view is small. Now I'm going to have my assistant. Oh, good. So he has the bile shield, I think, right here, which allows me with a water pump to fill the fundus up myself. And we really need to get good distension. So this is a very critical part of this procedure. If you want to identify the perforator, you want to distinguish the varices from collaterals. So varices are different from the collaterals, which are outside of the gastric wall. The varices are inside. You can swap the ETOH for large, please, now. All right, so now let's mag up one. So all I'm doing is I'm slowly pulling back. That's mag up. And where's the water puddle? Can I control that myself? Or you're doing it? Okay, that's fine. Please mag up a little bit more. So I'm slowly, you can see there are lots of bubbles. This is why it's better to use de-aerated water. You can put some simethicone inside as well if you have trouble. Looks like little fish in the pond. But I'm just basically pulling back towards the fundus. So it's worth taking some time to look at this. You can see there are lots of little varices here. small diameter varices. So a lot of those, what look like lingual folds, are probably varices, but the risk of these bleeding is very small. You want to focus on the IgV1 type of varices. So again, I'm coming slowly back, and we're going to look here into this area. So this is the part that takes a lot of patience. You have to slowly pull back. And what I'll do is I'll pull back now like see the cruce muscle. You see the cruce muscle at the top? I don't know if maybe with calibers I can show that really quickly. The reason for identifying the cruce muscle is, so it's going to be up here. I'm going to show it to you right now. Can you mag over me? How do we mag up? Yeah, there we go. And again, and one more time. All right, so this is here the cruce muscle. So this is the left limb of the right cruce muscle, and what we're seeing right here is very nice. Is you're looking transesophageal into the fundus. So the fundus is down here. See, this is the fundus, and we're going to look for our varices here. So the idea is not to do a transgastric puncture of these varices. We want to do transesophageal, ideally transcrural, because that provides the backboard so that you don't get any bleeding, any back bleeding. In fact, if you do this correctly, you won't see a drop of blood afterwards. So we're looking at transcrural, and this is also a great way to find the perforator vessels. So I'm just going to advance very slowly. So you can see very nicely the fundus here, and I'm just kind of pushing forward, looking for these varices. So it's important, and you heard this very nicely in the lecture this morning, that you can identify the muscularis mucosa of the gastric wall. If you can give a little bit more water, please. Fill it a little bit more. So you really want to extend this very aggressively. Okay, and a little bit more. So take your time. All right, that's good. And just be aware that there is a risk of some aspiration. So the varix that I'm probably going to target now is going to be here. I'm going to try to follow this and see if I can identify where the perforator is. How do you find the perforator? The perforator is going to be where you see it going outside and often connecting with gastrorenal shunts. You don't really want to start injecting into gastrorenal shunts because the risk of embolization is very high. So now here, as I turn down here, now we're getting a nice view of those bigger varices, right? Look at this. That's what we want to target here. So this is where I need an assistant holding the scope. And so here I'm kind of in a difficult spot where I'm forked like this, if the camera can show. I'm going to see whether it's possible. So this is a beautiful view. This is the view that I want. And you can see how it connects with the perforator out here, which will go in with collaterals. So this is, you can see the muscularis mucosa here. You can see the outline. This is where the water filling is so important. And we can also freeze just for a moment so that I can measure the diameter with the calibers. Okay, let's just measure the diameter of one of these varices. Well, okay, that's distance. But in fact, this varix is only this size, right? So it's really just 7. In other words, even though the holes are big, if you put a 20 millimeter or a large coil, it's not you're going to have some difficulty getting it to fill that. So you have to realize what looks endoscopically like a single varix is actually a convoluted of varices. They're smaller diameter, and that's why I think ETOH is necessary, because you don't really have quite the appreciation. Now, let me just very quickly see, because my assistant is going to be assisting me on the side. It's going to be difficult working the scope like this. I'm going to see whether I can just turn everything over like this and just see if I can get into the same position, but be closer for my assistant. It may or may not be possible. I'm going to see if it is. So pulling back like this here, and I'm going to see if I can get into that same position, or I can see the bigger varices down here. And yes, I think I've got it, right? So this is much better. You see that the scope is straight. right? It's going to be much easier. This is how you should be working with your shaft of your scope always straight, working because he's going to be more resistance. All right. So I think we're ready to get started now, and we're going to place a coil. And, I think in terms of size of the coil, we'll use a 19-gauge needle. I'm going to have an assistant holding my scope, though. Yes, please.
Good afternoon, Professor Binmoeller.
Yes.
Good afternoon. Now we can see the conglomerate for varices with the multiple septa. So where we have to target and how you decide where to target and how you calculate the size of coil.
So, ideally, you'd like to get as close to the perforator. I'm just trying to look here a little bit and sort of see which one I'd want to go for. Sometimes we have no choice and you just have to go. So this is what I like. I just look back into the stomach. Hold this right here, please, just like this. So you see the cruce muscle again up here. I don't know, can you put the arrow back here? Where's the arrow? All right. So the cruce muscle is up here. Yes, I've stood back into the stomach. You're looking across you're looking across to the fundus. So this is what I want to bring in here. This is the perforator right here. Right, you can throw Dalpa on there. You can see it very nicely. This is what I want to target here. Right here. If I can get my coil in this area going transcoronal, this is the cruce muscle, into the varix. That's the ideal. And this is where my assistant is helping me by just stabilizing the position of my scope. And once again, if we look and we measure, that is, I think we measured it already. It's just about 7 under, so I think we're going to use a smaller coil, not a big coil. You can use a 12.
So
It's a little bit larger than the diameter of the varices. So this is the part where your assistant plays such an important role because it's very, very easy to suddenly start going outside because we're targeting the junctional. So now I'm in the stomach again, right? So I'm going to pull back. Now I feel that you can feel it when it slips into the esophagus, and that way you're really going trans.
You're gonna target
Just like this, please.
You're gonna target the intramural part or a feeder.
I got to target the feeder as best I can. In this case, I can just sort of tell you where I think the feeder is.
So, Professor Binmoeller, till you are fixing the needle, I'm shifting to room number 1.
Okay.
And shortly we are coming back to you once you are prepared.
So we're in perfect position now. You can see the needle lengthwise here. This is the Boston needle that we're using, the 19 gauge. And I have a nice trajectory, I think, in terms of, I've already measured the distance. So I've already locked in the thumb screw here at 2.5 centimeters, because that's the distance I want to go in. So just going to make sure we have distilled water that we're using, because we're using imbutyl 2. Otherwise, I use the saline if I'm using 2-octal, which is my preference. So we're going to, as soon as I'm in, we're going to aspirate and confirm that we have blood return. As soon as we have blood return, we're going to flush some water, not with a new syringe, with just saline, the new syringe, and then we will attach the coil loader. Okay, I think we're ready now, and we have some respiration going on here, which is one of the reasons why I prefer to always have the patient intubated. So it's just a thrust like this, and I should be right in there, smack in the middle. We aspirate and see if we get blood return. We should. Good.
Cameraman, please focus the...
Very quickly switch for the... Never put gas in there. Okay, flush. You can see lots of bubbles. There they are. All right, now we're going to switch out to the loader, and we're attaching the loader, and we're going to push the coil into the FNA needle. So we're only going to push it far enough so that afterwards we can remove the loader.
What size coil you are using, sir?
And then we can use the this eyelet as a pusher to push it all the way in. So as soon as you think it's inside of the FNA needle, we take this off. Right? Perfect. Make sure you take the stylet out. You're going to use the stylet as a pusher.
Yeah, using a 12 mm coil.
Yes, 12 is fine. We'll pack them. Get the next coil ready to go. Right afterwards, we're going to put a second. I always put 2 coils, at least, sometimes more. All right, so you see how we're getting nice bubbles. We have great visualization. We're going to see the coil come out now. Look at that. I may adjust my position accordingly. Looks beautiful. It's very echogenic. No question, it's in great position. So what this coil is doing is it's slowing down blood flow. That's very important. And it will serve as a scaffold. The woolly synthetic fibers are going to serve as a scaffold to retain the glue at the site of an injection. So now the assistant is very skillfully advancing our second coil in. The loader comes off. So you want to silent?
How many coil and glue?
I'll put as many as where I see really that it looks like things have slowed down. So let's put at least one more coil. And the coils will anchor each other. So you can use smaller coils if it's okay. Just there we go. That looks fantastic. I like this. I think we have enough. You see it fills the lumen very nicely. We're ready for the glue. So you don't have to Doppler, but you can. So now let's put the glue in. So this is historical. We're using the N-butyl-2-cyanoacrylate. And this is, I guess, mixed with some Lepido, right?
Yes.
Okay, so we just want to make sure that it doesn't fluctuate. Yeah, go ahead. Push it in. The first part is going to go inside of the FNA needle, the dead space. And then we push that in from the dead space in. Put a second one in. Another. One more. I always put 2 cc's. Can you get one more in?
One more cc.
So you can just push. Yeah, push. You have to keep it open. Otherwise, the needle will. This is why I don't like this to grow. If you use the 2 octal, you will never have this problem. Now I have to pull out. But let me show you how to pull out. It's all fine, all right? But usually I put in 2 injections. So I put Dermabond or Exofene. This is 2 octal. And the most important is you do not want to get any glue under your scope. Now I can tell you because we went transcrural, probably all the glue is going to stay in the varix and it won't come out in the esophagus. But just to be sure, the first thing I do is I pull back my needle like this. Okay, now I'm inside. I unlock the thumb screw and lock so I never injure the assistant, okay? And now I'm going to advance the sheath into the lumen. Advance the sheath. And now I pull the whole scope out. I'm not going to pull it to the working channel. Pulling the whole scope out. And then once the scope is out, the assistant is going to immediately clean off the tip. And you see there's not a drop of glue on there. That's because I went transcrural into the varix from the back side. It's the back, the transesophageal is taking the back door to the varix. And the mucosa is, of course, very thin if you go transgastric. So this is why I try never to go transgastric, because then you're going to get some bleeding. So you just wipe off the tip, and then, just as a precaution, but in addition, since we have a balloon on the transducer, even if you got some glue on there, the balloon, which you can take off, will protect. All right, so now we can remove the needle, right? And we can go back in, and we can do another injection. It's just a repetition of the same, but you've seen the steps now. I'm just going to repeat the same thing I did, and I just want to make sure that I get all of the varices that need to be treated today treated. So I'm going back down. And, endoscopic, I'll put the endoscopic on just for a moment. Look at the water. There's almost no blood, maybe a little bit from the puncture.
Professor Binmoeller?
Yeah.
So Dr. Mahesh Goenka is waiting in another room. So can we switch over there? So over to